So we're going to do a full patient assessment here from scene size up all the way through secondary assessment and reassessment. So I'm going to come in to the scene here. I have my partners with me. I have a crew of two assistants with me who are at my level of certification. I am going to ask if the scene is safe. If the scene is safe, I don my BSI, my body substance isolation, as do my partners. In this case, we all have our BSI and we've made sure the scene is safe, and we made sure to note the time of day, the weather conditions that are around us, and are there any bystanders that we can get a history from in this case. As that can be valuable, it also is important to make sure that those bystanders are safe in the circumstance. So once we have done all that, we've ensured the scene is safe, we have our BSI and we've ensured bystanders are safe, and if there are any bystanders that could give us information, we've gotten information from them, and we're now entering the scene, and we're getting level to our patient. In this case, and my general impression of this patient is that they are a mid-30s male, have experienced severe trauma-related mechanism of injury, and that they don't appear to be moving, and that they need help. And so we are then proceeding into our initial assessment here. So first of all, I want to introduce myself. I want to say, hello, sir. My name is Alexander Gato. I am an EMR with the rescue department, and these are my partners, John Doe and Jane Doe, and they are also EMRs and they're here to help. And so after introducing myself, I would see if that patient responded to that verbal stimuli. If they did not respond to that verbal stimuli, I would want to then proceed to see if they respond to painful stimuli, rubbing their shoulder, pinching their shoulder potentially, not rubbing their neck, or pinching their neck, especially if I perceived that this was a trauma-related mechanism of injury. And I would want to ensure that my partner is holding C-spine while I am doing that. And once C-spine is stabilized and we've checked to see that our patient is unresponsive as a result of those lack of response to verbal and painful stimuli, I then want to begin assessing life-threatening conditions. So ABCs will be what we tackle next. So I want to check the airway if I'm using a jaw thrust maneuver. And then I want to look, listen, and feel for that airway. I want to be looking down the patient's body so I could see the chest rise and fall potentially. And I would want to see if I could feel the characteristics of that breathing, what the rate is, what the rhythm is, and the quality of breath, how deep or how much breath is coming out. And then I would want to then ensure that that airway is secure, is patent, and whether that would be placing NPs or OPs, and then ensuring if the rate of the respirations was too high or too low, that we are positively pressure ventilating this patient. I would make sure my partner is doing that using a BVM, in this case delivering 15 liters per minute of oxygen at 100% O2 saturation, and we're going to be making sure that this patient is getting adequate ventilations between 12 to 20 per minute from my partner. So we're taking control of that breathing, ensuring that we suction the airway if need be, and asking if we need to suction the airway if need be in the case of the scenario. And then we are then proceeding down in terms of, after having secured a patent airway, checking the breathing. We're now going to check for circulation. I'm going to check for a central and peripheral pulse, and I'm also going to begin exposing the patient, and I'm going to say, sir, I'm going to take your jacket off, again speaking to my patient as if they were awake, and begin exposing the patient, checking for a carotid pulse as well as a radial pulse on the wrist of my patient, seeing the quality of the pulse, the rapidness of it, the actual pulse rate, and the nature of the pulse, how strong it is, how whether it's thready and weak or is very strong and normal. And if I was able to determine a pulse on the carotid or the peripheral, I would then proceed to address any issues related to that now, especially if there was no pulse. I would want to ensure that you begin to perform the necessary medical interventions if we don't have a pulse. And then if we do have a pulse, I will want to note what the pulse is, and then proceeding from there, having bared the patient's upper torso now, taking off the jacket, I would want to examine the patient's skin, note the quality of the skin, and as I'm doing that, I'm going to start at the patient's head, feeling for any hemorrhaging, looking for bleeding, working down the patient, just feeling for bleeding, looking at the chest, making sure there's any signs of, noting any signs of bruising that are immediately apparent, looking for that chest rise and fall, seeing if it's bilateral or asymmetric as my partner handles the C-spine and the positive pressure ventilation of this patient. And then as I've noted the skin, as I've checked for hemorrhaging, taking care of the AVCs, stabilizing C-spine, I would then want to begin initiating that if the signs that we were seeing in this patient were reminiscent of a serious transport, if this patient was in severe distress and potentially going into shock, I would want to initiate rapid transport, get a paramedic intercept, alert a trauma team, which I'll leave to dispatch to do, and alert the hospital that we're transporting to have a trauma team on standby. Then I would move into my primary assessment. I want to feel the head for decap BTLS, checking the neck for any deformities there, looking for tracheal deviation or jugular vein distension, and then moving down into the shoulders. Once I've checked the neck for any step-offs or anything in the back of the neck posteriorly by palpation, and looking at the neck anteriorly for JVD and tracheal deviation, I want to place a C-spine collar so that we can get this patient ready for transport. I will now send my other partner who's to go get a longboard in order to stabilize our patient for transport. Again, I'm going to work down the shoulders, feeling the clavicles, then working one shoulder at a time, then pressing them together for stability, palpating the clavicles, working down the sternum, feeling if the sternum is intact, ensuring that I don't press any areas where there are bruising though, if there appears to be signs of crepitus or internal bleeding or bruising, and then working down the sides laterally, going into the abdomen, palpating all 4 quadrants, seeing if there's any rigidity, any tension, feeling the retroperitoneum space, the back of the patient here, to see if there are any feelings, again, of rigidity, of softness that's unusual in those spaces, and feeling those. Getting that upper torso covered, I want to listen to the lung sounds of my patient during this assessment, and again, noting the skin quality as I move down for a continual reassessment later. And then once I have cleared decap BTLS, checked both the anterior and posterior portions of my patient's upper torso to ensure that there aren't any immediate injuries that I can intervene in order to treat effectively and ensure my patient is getting the best quality care. I am then moving into the lower half of my patient now. Again, after feeling that retroperitoneal space, I am then working down the body to again see if there are any signs of internal bleeding represented by potential pooling of blood, dark patches, any sort of bruising that I note. Feeling for stability, not pressing down, but feeling for stability, pressing in at the hips, making sure the hips are intact. Then again, sir, I'm going to expose your leg, exposing the leg, cutting down the leg with my trauma shears, exposing the leg, feeling the leg for any signs of crepitus, any signs of bruising or internal injury that could be severe breaks like femur fractures, making sure to feel that pedal pulse as I go down to the foot and seeing if I get that pulse there. And if I don't get that pulse there, I want to note that. And then I want to see if my patient will respond to, again, verbal stimuli. Can you wiggle your toes? Can you press your foot up against my hand? Can you push down on my foot with your hand? And then moving to the other leg, I want to do the same thing, work down the leg, feeling for crepitus, checking for any sort of bruising or pooling of blood, and then get to the feet, check that pedal pulse on that leg, note whether I have it or not, and then feel that push up against my hand or away from it, and then again, asking my patient to do that. And then I want to move back up here to the arms. Expose the arms, sir. I'm going to just expose your arm here. Take your jacket off. Feeling the arms, checking for a radial pulse, just ensuring that there are no injuries that I can treat as I go along. And then as I find problems, I want to be able to fix them. And then coming over here, working down the arm, doing the same thing, feeling for that peripheral pulse, that radial pulse right here. And see, again, noting if I find those pulses or not. At this point, I've worked my patient from head to toe, finding problems, fixing them as I go, and then we're going to now get the backboard, which has arrived from my partner. I want to roll the patient on the side where there are no injuries to that patient for transport. We have a C-spine collar placed. We have the patient being ventilated still. I have noted any signs of crepitus, bruising, or potential internal bleeding throughout my patient. Noted any fractures or breaks that could be apparent, and ensuring all those things are taken into account and that my patient is stable enough to move in this moment. I will then move them in a log rolling fashion. So if this was the side closest to me without injury, I would roll them towards me, then back onto the backboard. So my partner would be controlling the backboard here. And then I will want to assess that posterior side once I roll them over. On 3, 1, 2, 3. Patient is rolled. Want to feel, look, see if I see anything that could be an injury that I did not account for from my anterior, mostly anterior assessment of the patient. And then putting that patient onto the backboard, which is now there. We are now moving into the ambulance, and we are going to begin transport of our patient to the hospital, which again has been alerted. Trauma team has been alerted. We're on our way to a paramedic intercept. So now we're going to begin our secondary assessment. And our secondary assessment is going to, again, start at the head and work our way down. We're going to feel for decap BTLS again. Again, always checking our hands to make sure that there's no bleeding or anything of that nature. Checking in the ears to ensure that there are no fluid there. There's no bruising that could be representative of a skull injury behind the ear of our patients on both sides, and then ensuring that that head is completely clear. I would want to then do more comprehensively, again, feeling that anterior portion of the head, the face, making sure that I'm feeling around all the bones of the face, ensuring that there are no raccoon eyes or anything of that nature that could be reminiscent of a serious head injury. And then working again down into the shoulders, feeling the shoulders one at a time, feeling the clavicle, stability check, feeling that sternum, making sure it's intact, palpating the abdomen in areas, all 4 quadrants, making sure that there's no rigidity there, feeling the retroperitoneal space. Again, I'm gonna listen to my lung sounds again. I got my stethoscope on, listening to my lung sounds, and I should have mentioned that I would have checked the pupils of my patients at this point, looking for pearls, seeing if they're equal, if they're reactive, what size they are, if they respond to light or not, and ensuring that those aspects, those qualities of the pupils are noted for PCR. And so as I work down, again, feeling for stability, pushing in, not down, feeling for stability. If I had found any injury here, I now want to have my partner who had gotten the longboard to splint the injury. Splinting the injury, checking again for a pulse, checking for any signs of medical tags as I go on any parts of the body, the neck, the wrists, the ankles, where they could be, and then ensuring that the intervention is potentially working. I would want to check for that pulse again, see if pulling traction and splinting this injury, if it was injured on this side, if this patient was injured on the side, then I would want to check for pulse, check that pedal pulse after traction splint has been applied, see if we have a pulse. again, noting that pulse if we were able to attain it now that we've done an intervention. Checking for capnography in the toes as well. And then working down the other leg, doing the same thing, checking the pedal pulse. Again, and on both of these legs and on both of these feet, checking to make sure, can you push down on your on my hand with your toes? Can you push up on my hand with your toes? Can you wiggle your toes for me? And then proceeding, again, once I've checked the legs fully in that manner, moving back up the body, again, checking the arms again, checking for a radial pulse on this arm, checking for injuries, checking this arm again, sliding down the arm as I go, making sure there's no injuries, checking for a pulse, noting that pulse. Now I'm going to take a blood pressure of my patient, want to know what that blood pressure is, and then I would want to, again, keep monitoring my patient, assessing them if they were, in this case, a serious injury every 5 minutes, ensuring that they are hooked up to a 12-lead ECG so that our paramedic intercept can have that information when they arrive. We'll do a blood glucose on this person to ensure that we have their blood sugar level as well. And we are now in transit to the proper facility for this patient and on our way to our paramedic intercept so that ALS can help us manage our patient in this call. And yeah, and that would be our entirety of our from scene size up through initial assessment, primary assessment, secondary assessment, and again, reassessing every 5 minutes as we're in transit to ensure that we are taking note of changes in the signs that we are obtaining from our patient.